So in the next 15 minutes, I'd like to talk to you about the management of intraabdominal or intrapelvic complications of Crohn's disease, including fistula and abscess. And I have nothing to disclose as a conflict of interest. So when you deal with a Crohn's disease, when you get these patients at the sitting with an abscess and a fistula, what can be humbling for them and for us, it seems like, why is there a chance that we could have worked better to see these patients earlier? And was there some set goals that we could have done together with our gastroenterology colleagues to set the goals and get the directions for future treatment rather than having the patient to come this complicated? It's okay for the Crohn's to get complicated, but not to have the complication to get more complicated. Now, what does that mean? One of the things that means is, when the patient comes to us with this humbling problem of a fistula or abscess, it's really the most frustrating aspect for the surgeon, and it's peculiarly unique to the patients. As much as we define this as a failure of medical therapy, but when we deal with a Crohn's disease, and unfortunately, despite all the wonderful drugs that we have, still the surgeons needs to be and will be part of their care at one point in their life. So to define as a failure and having them to see the patient at that stage is like putting us into a spot in the situation like Dr. Evil is waiting at the corner with a knife ready to attack the patient. And that is not that fair. So how can we do the things better in these circumstances? So number one, this is a very old, the slide that we didn't have a CT-guided drainage system. We had to drain these things surgically. This is a mesenteric abscess, the pus comes there, and these patients did not do that well because of a less conservative therapies were not existing. So today's management, when the patients do come back with an intraabdominal pelvic abscess, number one thing we like to do is CT-guided drainage, cover them with the antibiotic coverage, await the resolution of the sepsis, and further work up to delineate the anatomy, colonoscopy, CT enterography, and drain injection. It's just like getting a roadmap. These patients is a type of situation, it's like a strategic war game because it can be so tough, so humbling for them. Trying to be prepared for the unexpected is the key. And our approach, at least in our institution, most of the times, which can be controversial, that surgery in 6 to 8 weeks after the dust settles. Now, some of the time, the people can make an argument, I can get started with the medical therapy, biologics, or anything, and then treat the patient. That is something we've been a little bit stayed away from, and I think it paid us off well. We do have pretty good results, and we have a wonderful gastroenterologist, and then they can over and treat the patient after this management of a complication of the disease itself. And when we look at the literature, this is the paper from our friends from Guangzhou. 9 studies, they look at the meta-analysis like 513 patients, and the overall complication rate was significantly higher in patients undergoing initial surgery compared with those undergoing initial percutaneous drainage. So they compared the results, patients who had initial surgery versus percutaneous drainage. And their results showed the fact that although abdominal surgery appeared to be inevitable in the majority of the patients with the Crohn's disease who develop intraabdominal abscesses, proper percutaneous drainage may decrease overall complication after the surgery. So what it does is it cools off the sepsis, takes care of the infection so we can take care of the patient without getting into trouble. I think this is one of the techniques that really revolutionized our armamentarium in the last 15 to 20 years. But unfortunately, this is a situation that we regret to see, but unfortunately, we still see. This is a patient of mine that it was a very humbling case, took us for a whole day to do it. It was a Crohn's / the surgical complication of the situation. And that's the point. So when it's related to Crohn's disease, because if it's related to Crohn's disease, fistulized disease is usually considered a very aggressive form of therapy. And asymptomatic fistulas that enteric or enteric fistulas that you may leave them alone. But if they have a significant amount of symptoms, then these patients need to be necessitating surgery. And our dear friend, Dr. Atreja, had this analysis, said the fact that about the medical therapy of an enteric or enterocutaneous fistula therapy, I think this is summarized the situation. The conclusions about whether biological therapies can prevent or delay the need for surgery in a specific subset of fistulizing Crohn's disease or lead to sustainable improvement in quality of life is lacking in current trials to guide physicians regarding when to consider biological therapy alone in conjunction with surgical options. But beside the Crohn's itself causing this fistulous disease, that there's a significant amount of the problems that is caused by us, which is iatrogenic. Because the Crohn's and IBD is a different pathology, and these patients are more prone to leak and infection. We also have to deal with this type of pathology in the presence of Crohn's disease. So when these things develop, I think we need to know about the principles of the surgery, and especially having a reliable gastroenterologist who knows these things is a lifesaver. Do you know what? Most of the patients that I'm privileged to get referred for these type of surgical complications, unfortunately, do come from gastroenterology colleagues. So there are three phases: acute, subacute, and repair phase. At the acute phase, after the fistula happened, after a surgery for Crohn's, 60 to 80% usually gets healed in the 6 weeks' time, and everything is done. But the good amount of them do not get healed. So the art of the colorectal surgery is to define the strategy. You need to think about not that surgery, how about the next surgery? Because the Crohn's is a lifelong disease. So the art of a good colorectal/IBD surgeon is to be able to think 2 or 3 steps about the procedure and the patient, because it's a lifelong relationship. And the general principles, when you get a patient like the one that I showed you, you need to be humble. You need to come there with the ego aside, schedule the first case, and get some help that you need to be getting from your colleagues. Get the anesthesiologist's help, urologist's help, and exposure with the visibility. And the most important prognostic factor in these situations, specifically for me in the management of IBD and management of reoperative surgery in the setting of the IBD, is the surgeon. And one of the things that I always try to teach to my fellows and residents, when you get into these complex situations, that always have an exit strategy, that you have a bailout strategy, and surrounding the enemy. I call the pathologist's enemy. Don't go and pick up a fight directly with that fistula and abscess directly, because you will lose. You need to surround the pathology, come there. And we're going to have a video shortly about this thing. So when you come back to a patient after a perioperative period, you need to know when it's okay to go back in there. Because the first 14 days you can go back if somebody developed a bad sepsis, but if the patient developed a fistula and no associated sepsis, they're just draining, you don't want to go back between 14 days to minimum 3 months, because the adhesions are like an envelope stuck to an envelope, and you create a nightmare problem. So many patients are hurt with this thing not being known or not being respected. Go back at 12 days, go back there 3 or weeks or 6 weeks. You get into a pathology, you make multiple holes, patients with an IBD, and they're stuck with that with 2 to 3 years of a pathology that is tough to handle. So when to operate? Wait for 6 months, check for the abdominal mobility. Both hands applied to either side of the abdomen. Vigorous back and forth motion. If they're mobile, like a bowl of jello, it's okay to go back. If they're still rocked, then you wait longer until the dust settles and handle the patient with a TPN during that time. So let's talk about the surgical principles. This is a postoperative complications of a Crohn's that came back with multiple fistulas. Despite the fact that this patient doesn't have an active Crohn's disease there, he still was not respected with the disease pathology, not diverted properly, and guess what? For the sake of avoiding 3 months of an ileostomy, he got stuck with a pathology that he had to deal with for 3 years or so. So surrounding the enemy, this is what I try to teach. Get a mental set that you need to surround the pathology, don't pick up a fight, get the help you need, because you're going to be tackled. Our Creator gave us planes to use in an anatomy to dissect. So go from known to unknown. That's something that I always repeat in the operating room. Don't go into create your anatomy that you have no idea where you're going. Find the God-given planes to be able to know where you're going. I think it's very critical. And this is an example of that. We stayed all around the tissues, excised the skin. Now we're surrounding the enemy and handling the pathology. The toughest thing for me to teach to the trainees for the future and now is when not to operate. So respect the pathology. If it's a little bit out of your league, or if the adhesions are really bad on these complicated situations, back off. You can always come back another day and give a high diverting jejunostomy on these patients and send patients to some place that they may have a little more experience handling these problems. More patients are hurt by pushing the limit, by excising the small bowel and having the patient end up with a permanent ileostomy, a short bowel, by not being respecting to this principle. Again, avoid the unexpected in the operating room. Don't overwork myself. Get the proper workup from the surgery. Expect the unexpected. Get these exposure and the visibility. These are the positioning things that we do. We put the arms tucked on a legs up position. Get the lighted instruments and always leave the hardest part to end. Enter the abdomen through the easiest part, which means no incision if the patient had prior surgeries. Get a proper exposure and get the bowel decompressed and deliver them outside so you can lyse the adhesions later. Sometimes we have to do this saline injection. Saline injection is separating the bowels. Sometimes we have to take the fascia with the specimen that we're working so we don't create holes. Anytime you have a tear or hole, repair it. Otherwise, you may regret the fact that you haven't repaired this. You may come back 5 to 7 days later with a fistula again coming inside the wound. And leave the hardest part to the end. So this is a simulation that's injectable saline when the bowels are really stuck and they cannot be separated. By giving injectable saline, it separates the things apart, and we can operate on these patients by finding the tissue planes easy. The Crohn's is a humbling disease. We need to be prepared for the unexpected. We always look like to have the good guy to see us, but when we're not ready, we may be very, very unpleasantly surprised with a difficult situation. And this is a patient of mine that we did like a couple weeks ago. The pathology is not a Crohn's disease, but the principles of it is the same. This patient had a major perforated diverticulitis, studus post heart mouth procedure. He had a studus post appendicitis, and they were worried about the Crohn's disease because they developed a fistula. That's the pre-op picture. So this part is the top of the patient. The blue part is the feet of the patient. So we're surrounding the enemy. That is the fistula to the skin as an intracutaneous fistula. We are getting from known to unknown, finding a room to be able to dissect further. Not picking a fight where exactly the fistula is. This is what I try to preach, and I told several times. Surrounding the enemy. Going back in there, major infection still stuck there. Take your time. Don't get frustrated. Go back to someplace else, separate the tissues, and surround the bowel loops. So it's getting thinner. Thinner, the fact that we'll be able to amputate one part of the fistula here. He had multiple fistulas in one segment. And this is the part is after we circled the pathology, and then this is again the same concept, going from around it and from the other side, and we're disconnecting the pathology itself. This is again surrounding the fistula from the other side. He had more than one in that area itself. And it can be seen here, there's a further pathology there with the fistulations being carrying out. But this was the external fistula from the outside. And this is injectable saline. Again, the strategy, injecting some saline into that area and then dissecting it. I don't know whether we were able to appreciate how it separated the tissue, so we were able to separate the things apart to be able to dissect it. Initially, there was no tissue plane. When we injected the saline, it was able to give us some anatomy to be able to work with. I think this is important. At the end, multiple matted loops of bowel, as I was said, is all together related to this pathology, and Crohn's is one of the most common reasons it does that. And we're separately taking our time to be able to, to separate the things apart. Injected the saline, that dissected that in tissue planes, separated that fistula. Now this is coming from the old part where it was operated, that was the source of that fistula. Always check for the other people's footsteps when you come for these reasons. That green was a suture that was used before. And after these are separated, again, surrounding the pathology, and then we're taking that one loop from another one. Again, envelope stuck to a stem. After all these things out, this is the last bit of the other part of the fistula, like one bit at a time. This is again showing that surrounding the pathology and removing that thing, and then removing the last bit of the fistula. The pathology at this stage is unidentified, and now we're going to remove the segment of that ileocolic disease with multiple fistulas. This is the main one that goes there that made this patient's life miserable. And this is an anastomosis that I like to do as an end to side anastomosis. This is the small bowel, ileum, and the cecum was there. That the colon, the top is there, that the circus stapler is put, and we did an end to side anastomosis. Cleaning the infection is very good. We use the uterine curette to clean the things, and I'm very liberal about diverting these patients and draining them. Again, principles, think 2 or 3 steps ahead from known to unknown, and circling the pathology is very important in these situations. When you deal with these things, you got to make sure to be liberal about the stoma, because the last thing you want for these patients to come back with the same pathology, guess what? Rather than 1 year they suffered, they'll be suffering another year. Be humble in these situations. Don't be afraid to ask for help. And specifically, for meetings like these, I cannot thank for Dr. McDermott and Dr. Hanover and the organization group allowing us to, as the surgeons, to be part of this group, because I truly believe about one of your colleagues who said that. If you want to go fast, go alone. And if you want to go far, we need to go together in this pathology. Thank you so much. I appreciate your time.
That was a great talk. Thank you.